Welcome to the Longevity Formula with Dr. Brandon Crawford. Let's explore the new era of wellness.
Hey everyone, welcome back to the Longevity Formula podcast. Thank you for joining me again today. I want to start by just saying thanks for tuning in. I really do appreciate how many people have been joining across all the different platforms. It's really been amazing, to be honest. I wasn't really sure what was going to happen. I didn't know who was going to be interested, but we've received just so many comments. I've had, patients reach out. I've had people that were thinking about being patients. I've had people that have just been affected in so many different ways, which is the goal. So I'm very happy with how this is going and just want to again say thank you. One thing I do want to say is I want the opportunity to connect with everyone. I want everyone to have the opportunity to communicate wants and needs and ideas and just give us your comments. So if you have any comments or you have anything that you want to share or say to us, maybe some ideas about some content you want to hear, go to drbrandоncrawford.com. So that's drbrandоncrawford.com. And in the top right-hand corner, you're going to see, if you're on a phone, it'll be those three little lines. Click that, and you'll see a blue Let's Connect button. If you're on a computer, there's just a blue button in the top right-hand corner that says Let's Connect. Click on it, fill out the form, send it in. I anticipate getting a lot of these requests. So if we don't respond back to you, don't worry, we're still reading everything, and we're going to be adjusting things and putting your input to good use. So thank you so much for that, and I look forward to hearing your comments. Today, we're going to actually dive into the Fear Paralysis Reflex, okay? And that may sound kind of weird. You may not have ever heard of this. Even a lot of the clinicians and therapists listening may not have heard this. But what I'll tell you is that the Fear Paralysis Reflex applies to us all. This is a very broad-reaching reflex. And I'm going to start here in a little bit by just diving into all of the different conditions and things that one can experience that are related to this reflex. So first, what we're going to do, we're going to do that. We're going to talk about how this may present in your life, what conditions this can be applicable to. But then we're also going to discuss the brain networks associated with this reflex. For all you nerds out there that want to know that information, I know that I want to know that information because when I'm working on a patient, I definitely need to be able to isolate a network so that I can co-activate it and whatnot, right? So I can actually rehab that person. But it's good to really understand this. And when we understand what networks are associated with the fear paralysis, or even indirectly associated with the fear paralysis, what you're going to see is that this is really a whole brain experience. And I'll make that make sense to you, right? But then more importantly, I'm going to give real strategies that you can begin using today to really start to help overcome all of these different things, right? So let's talk about what these things are. So I have a list in front of me, right? Because there were so many, I couldn't just rattle it off the top of my head. And these items, the majority of them are coming from the research. Some of them are coming from my clinical observations. I'll try and let you know, which is which. But the majority, if I don't mention anything, are actually coming from the research. So, chronic regional pain syndrome. This is a big one. I've treated many CRPS patients. And the fear paralysis reflex is a heavy part of rehab that we have to address. Sometimes initially, before we really even get into all of the other types of therapies we do, we have to actually address this first very commonly, right? So any type of chronic pain syndrome, but especially those central pain syndromes like CRPS, dysautonomia. So if your autonomic nervous system is dysregulated, something like POTS, which oftentimes does come along with CRPS, it's a part of it. This is another reason to look at the fear paralysis. Syncope, which is where someone faints. So if someone has fainting episodes or even just that lightheadedness, that can be random, or when they go from sitting to standing, this can be associated. Anxiety is a big one. The fear paralysis is absolutely connected to anxiety. It will drive it. It can actually be at the heart of it. So I'm going to give you some really good strategies to actually overcome anxiety at home. Of course, I want you working with your medical provider as always, so that you're under proper medical guidance. And this is not a substitute for any type of medical care or medication or whatever it may be, right? Depression, plateaus in rehab. So this is a big one. Then this is a clinical observation. I'll see people from all around the world, and it's very common that they come in and it may seem like a relatively simple rehab strategy that needs to take place, but they're not getting results. And oftentimes that is because they have this ginormous fear paralysis response standing in the way, right? That's huge. Sleep disturbances, that's documented in the literature. Social withdrawal, especially in autism spectrum disorders, but also in anxiety and people that feel the need to just withdraw and you don't know why. You don't want to be around people. You can't stand people. You just want to withdraw. Social awkwardness, shyness, locked in syndrome, like what we see in a lot of our brain injured patients. You will actually be in that locked in state. And that is the deep dorsal vagal complex part of this fear paralysis reflex, freezing everything and keeping you locked in because you're conserving energy and you're trying to heal the brain, right? So that's a big part of this too. Temper tantrums, that can be a part. Sensory processing disorder, pessimism, the glass is always half empty, those people. Paralysis there can be implications in paralysis here. Dyskinesias or tremors, especially when under stress, makes them worse. Low blood pressure, low heart rate, altered heart rhythms, things like AFib and others. Body temperature dysregulation, someone that's constantly hot or cold or constantly flipping. Breath holding, and this goes back to CRPS. We see this a lot. If we start to do some core activation with someone with CRPS, many of them actually hold their breath whenever they really go to do anything. And that's that fear paralysis triggering. You're getting that breath holding, and that is part of the fear paralysis. But you also see this in a kid. Maybe they're screaming, trying to get their way, and all of a sudden they start holding your breath. That's part of the fear paralysis. Hormonal changes, I'll talk about how that can happen. Inflammatory changes, autoimmune implications, and just general poor adaptability. Just being inflexible, not being able to really go from one moment, one scenario to the next. And it's because that fear paralysis is triggering and you're freezing and you're not able to quickly shift in those scenarios. Chronic fatigue, because you're going back and forth between the dorsal vagal and the sympathetic tone. Headaches, migraines, huge here, obviously, with the change in blood flow and everything that happens in fear paralysis. Headaches and migraines are often a symptom that we see. Sudden infant death syndrome, that's Dr. Porges' work that has connected this polyvagal theory, right, in sudden infant death syndrome. Post-traumatic stress disorder, huge with fear paralysis. Panic attacks, anger, right? And again, I know that that's a long list, but these were things that are in the literature. I gave you some things that I've seen clinically. So going back to this fear paralysis concept, you may never have heard of it, but I can promise you that 100% of people listening to this podcast have dealt with the fear paralysis in some regard, because we don't live in a bubble. Anytime that we have something that tells our brain, you may not be in a safe scenario, this could be a threat, there's a small part of that fear paralysis reflex that fires, because what I'm going to discuss is that it's not an all or none response. So we've all experienced this fear paralysis in some regard, but it's a big problem for those that cannot regulate it, cannot build the brain up in certain areas that we'll go over that allows you to suppress the reflex when it's not really a threat coming at you. Maybe it's someone that maybe they're ugly, or maybe you don't like their tone of voice, or maybe, right? Just things like that could be triggering to your subconscious brain. But your conscious brain can turn on and say, that person appears to just be having a bad day. Let it go. They're not coming after you, right? Some people don't have that ability because it's a very highly developed part of the brain, specifically the prefrontal cortex. So that's kind of the short of, how this is affecting people, what kind of conditions and what type of issues are going on in people that are exhibiting a strong fear paralysis. Now, let's get into some discussions about this. So would it be beneficial for a species to inherit a fear response? And what I'm going to say is yes, because again, our brain is all about safety and efficiency. So if your parents or your grandparents or your great-great-grandparents, etc., survived long enough to reproduce, then they want to inherit, they want to give their offspring the genetic composition that allowed them to survive whatever traumatic events they went through. Whether that was a war, whether that was physical abuse, emotional abuse, whatever that was, they survived it. And they want to propagate offspring that will be able to also survive and overcome those scenarios. Therefore, you may be someone that inherited a part of a fear paralysis reflex that maybe came from a great-great-grandparent in World War I or World War II, or maybe your parent was traumatized in some way, and maybe they developed a general anxiety disorder, but maybe you inherited that fear paralysis and it's affecting your gut motility, right? It could be same or similar neural networks, but it could be presenting differently in you, but it's still this overarching umbrella of the fear paralysis reflex that's being inherited to promote survival of the species. Unfortunately, our brain is not necessarily trying to make us happy, it's trying to help us survive and reproduce. Again, going back to safety and efficiency. So, can you see the fear paralysis on labs? I know that's kind of weird, but it was a way that, I was trying to figure this out. What does this look like from a clinical perspective? What does this look like on an exam? What does this look like chemically on labs? And the answer is yes. You have to be able to identify certain patterns on labs, but we have this thing called the senescent associated secretory phenotype, the SASP. I'm going to get more into that, but that is largely where we can see the fear paralysis on labs. And then there's more obvious things, more organ-specific lab findings, things like the adrenals. So if your adrenals are firing for a long period of time, like you're running away from a bear, or you're constantly being micromanaged by someone at work, or you constantly are coming in contact with a spouse that's emotionally abusing you, or whatever that may be, your adrenal glands are going to constantly be firing, and thus you're going to have elevated levels of cortisol. You can find this in the blood, you can do salivary tests, you can do urinary tests, there's multiple ways to test it, but that will happen. Now, over time, if you have this very chronic problem, then you can have this downregulation of the adrenals, and that's when the fear paralysis really sets in, because then you start to become more dorsal vagal and shut down. At that point, I start to think more along the terms of what's called multiple systems atrophy, which I'm going to talk about in just a little bit. But then you actually start to find very low cortisol and other findings. So that's one thing. The thyroid actually is very connected too. And really, this can go both ways. You can find a low thyroid, you can find a high thyroid finding, you can find various types of markers abnormal in the thyroid panels. You'll see gut health alterations. We know that acute stress alters the microbiome, as does chronic stress, and those look different. Immune health, and this kind of gets into the SASP that I'll talk about in a little bit. And then there's also stem cell implications where an acute stressor and a chronic stressor will alter how stem cells proliferate and differentiate. So that then begins to affect our ability to regenerate. It affects our longevity. It affects our overall health and wellness. So let's talk about this thing that I mentioned, the senescence-associated secretory phenotype. There's a good article. It's out of the journal called Cytokine that I'm going to reference or suggest that you read if you want to look more into the senescence-associated secretory phenotype. When it comes to this, you really have to start to learn how to find patterns. But basically, senescence, and I do want to do a whole podcast over cellular senescence. It's just super nerdy, and I don't know if you're ready for that yet, but we'll get there, right? I'll try and make it as fun as I can, but cellular senescence is that's how it sounds. So senescent cells of any origin reprogrammed they reprogrammed their genome and metabolism to become secretory cells. Now, what does that mean? That means that if you have this thing growing, let's just reference a tumor. Okay. If you have this tumor growing, because that's where a lot of the initial research came from, and you're not able to deal with it, your immune system is weak or imbalanced or whatever it may be, those cells will actually become dormant by certain processes in the biology in your body so that it doesn't continue to grow. And so you turn this rapidly growing set of cells into a dormant set of cells. And now they become more of a secretory set of cells, and they're secreting things like cytokines and chemokines and different types of cellular signals that are signaling to the body, hey, I've now become senescent, I need help. And that's a normal process that we're all going through, and it should happen. You do want a little degree of that. Like I was referencing in reference to tumors, that's in part how we prevent cancer, right? Within us, just a whole, natural mechanism that should occur. Or what if you hit your head, right? You have this mild to moderate or severe brain injury, and you have this inflamed state. And in brain injury, I talk a whole lot about the energy crisis that happens initially with a brain injury. And if you want just a little bit of information on that, if you think about, so I live in Texas, so if it ices over in Texas, everyone goes inside and turns on their heaters. And this taxes the energy grid, okay? So everyone's sucking down a lot of electricity, and we start to have these rolling blackouts because the energy grid is way too taxed. The same thing happens in the energy crisis in the brain. You have this whack to the head, and that's not good, obviously, because the brain actually consumes 20% of calories that you put in your body. It's 2% of your body weight, 20% of caloric expenditure. And so it's very energetically demanding. And so if it's trying to heal itself, that energy demand goes way up. And so you start to actually see these rolling blackouts in the brain. That can promote senescence. If you're not able to fully heal a brain injury, if you just go to a doctor that says just sit and wait, just go inside of a dark room, stare at a TV all day, which are not good advices. That's not what I would suggest. There's actually very good stepwise progressions about how to heal a brain injury. I was just working with someone a few months ago. They clotheslined themselves, whacked their head, had to be air transported, went to the ER. The parents, I think, if I remember correctly, reached out to us from the emergency room because the ER doctor was just saying, oh, just, rest and wait. And they knew that more could be done. I just did his follow-up yesterday, complete recovery. I mean, literally, I had to really look to find any kind of deficits after they went through our program and did the home care and all the things necessary. But if someone doesn't do the right things, then you can have this development of senescence within the brain. And that can obviously spread. And as cells go dormant in the brain, that can lead to dysfunction. It's being connected with neurodegenerative disorders, dementia, all types of problems there. We see that the SASP mediates tumor suppression, like I was talking about, wound healing, but also chronic inflammation and age-related diseases. The transcription factors NF-kappa B and the P53 pathway in the liver are heavily implicated and control a lot of this. And then one little note that you're probably going to find on your Google searches is metformin is a drug that they've actually studied. And I know Dr. David Sinclair references this a lot regarding health and longevity and how it influences the AMPK pathways and the sirtuin pathways. But this can inhibit the inflammatory components of the SASP. I'm not saying go and start taking metformin. That's not what I'm saying, but you're going to see that. For some, maybe it's a good idea, but I personally have not had to implement that clinically at this point in time. We found other strategies. So that's a little bit on the SASP. But again, there's certain inflammatory patterns. There's key markers, NF-kappa B. I do look for C-reactive protein, homocysteine, and these types of things to really start to note and objectively measure from a lab perspective how we're treating the fear paralysis reflex, and also gauging where someone is in that reflex progression. If this process continues, right? If you let this fear paralysis, let's call it pathology, right? If this is becoming unregulated and you do not have the cortical integrity, or you lose the cortical integrity to really regulate it and control it, this can then start to turn into what I referenced earlier called multiple systems atrophy. And this is really where you've gone through this fight or fight phase. You've been trying to recover. You've been trying to run away from a stressor, fight or whatever. And now the body is running out of resources. It's nutritionally depleted. It's energetically depleted. And now you start to see actual organ systems go offline, right? I mentioned the adrenals, but you can see this in liver failure, kidney failure. I have a patient story I'm going to share with you today who actually had his GI tract shut down. So I actually experienced gastroparesis. He was in the GI failure unit multiple times, and they really couldn't help him. And that's why he came over here, because no one could offer him any hope or any suggestions. And we've got him moving in the right direction. So that's what this can progress into. And I think it's important for everyone to understand this, because this can happen to anyone. And I've seen it happen with multiple people, where maybe it started with a moderate head injury, or maybe it started with an anxiety disorder, or it started with a pain syndrome. And then it's just rapidly progressing. And that's winding up this whole process via neuroplasticity. And it turns into multiple systems atrophy. And that is difficult. It's difficult for everyone, because there's no real answers for that in the medical community. So let's do this. Let's talk about, again, let's share this story from the UK. So this is John's story. And if you're on YouTube, you can watch the story. If you're not, you can just listen in. But I think it's really important to listen how someone who is very intelligent and very functional ended up, again, with this pain syndrome, and then ended up in the GI failure unit, was on very large amounts of morphine just to get by. Nothing was helping. He couldn't eat. And so he was looking pretty grim. And the first thing we started to address were these fear paralysis mechanisms. And he made a great recovery. So listen to this, and then we'll get going again.
I was at the point of just, almost giving up. This is it. This is how you're going to carry on for however many days you've got left. I can't really do anything of a day-to-day. If I present myself to any degree the following day, I'm bedbound. Prior to coming here, everything was just about, one, keeping weight on, and two, sort of maintaining a level of pain that's tolerable. So I have to take a lot of morphine, which I don't like at all. My goal is to maintain the weight, get rid of the pain, and have some sort of level of not being able to do stuff without being so fatigued. It's awful for my son and my wife as well. I just don't feel like part of the family. But now, we went swimming on Sunday. That was just a nerve. It's the second day. I woke up and I got out of bed without any effort at all. Whereas the previous week, it would have been touch and go whether I would have actually been able to get to the centre. Then that sort of snowballed. Now I've got more energy than I've had in at least 7 years, probably more. Energised both physically, I want to do things, but also mentally I'm now prepared and want to do more. Yes, I'm a different person from the person that arrived.
All right. So like I was saying, that, John came to us. He's not the only one that we've seen in a similar state. And it's very sad, because you have, like, for example, clinics that say they specialize in chronic regional pain syndrome, yet they know nothing about the fear paralysis. They know nothing about how to really help these people on this level. And they're just putting people through, a series of different types of physical therapy modalities, or whatever you want to call it. And they're wondering why some people end up with seizures. And they're wondering why some people end up going to the ER. And they're wondering why, and it's sad, because this is a big, big part of the missing link. So let's try to dissect, what is this fear paralysis? What is this reflex? Where is it coming from? There's a lot to discuss here, but what I'll tell you is, let's first reference the polyvagal theory, okay? So polyvagal theory says there's not just a sympathetic nervous system and a parasympathetic nervous system. there is in fact two different parts to the parasympathetic nervous system. And that's divided into the dorsal vagal and the ventral vagal complexes, okay? So if we talk about polyvagal theory, we now need to overlay the developmental component to this, because in the womb and early in life, we're mainly developing our dorsal vagal complex, right? Now, the dorsal vagal complex, when that fires, this is the part of the neurology that essentially shuts you down. This is the part that plays possum. This is the part that says, I can't run away. I can't fight this stressor. I'm going to then shut down, right? And essentially, if I had to give like a succinct definition, what is the fear paralysis? It's essentially an overexpression of our dorsal vagal networks. Again, our brain is just trying to keep us safe, is just trying to conserve energy, which in large part is another reason why you get that shutdown effect, so that you can conserve energy to perhaps get a burst of energy through the sympathetic tone, which we're going to talk about later. But from a developmental perspective, you should develop this dorsal vagal complex, because when you're born, you're a baby, you can't really voluntarily move, you can't fight, etc. So being able to shut down and feign death is actually, a way for you to survive. You're reliant on your parents and others to actually keep you safe. But then you develop your sympathetic nervous system. And your sympathetic nervous system is your fight or flight. Most of us know about this. So when you are able to have better muscle tone and you can start to defend yourself, now you start to move more and you start to develop that sympathetic tone. Then you should continue to develop, and you should develop what's called the ventral vagal system. The ventral vagal system is the newest part of the parasympathetic nervous system. It is myelinated. The dorsal vagal complex is not myelinated. And the ventral vagal complex is associated with the nucleus ambiguus. That's a fancy term that many of you probably don't care about, but it does have specific cranial nerves associated with it. So cranial nerves are these nerves that come out of our brainstem and supply different parts of our face, different parts of muscles up around our head, and various types of autonomic reactions, organ function, etc. So the cranial nerves associated with the ventral vagal system are cranial nerves 5, 7, 9, 10, and 11. And that's very important to know whether you're a clinician or someone at home. If you're someone at home, don't worry, I'm going to give you the correlation of how to stimulate these nerves. But as a clinician, this now gives you a window in of how to examine the ventral vagal system and then how to stimulate it, because you want proper ventral vagal tone. And the reason is because within this system that I just described, dorsal vagal, sympathetics, ventral vagal, you actually develop what's called sequential degradation. What that means is, as you develop the next part of that nervous system from a developmental perspective, it then begins to inhibit the older part. So the dorsal vagal being the oldest part and associated with that shutdown effect, after the sympathetic tone is developed, the sympathetics say, hey, let's not shut down, let's run away or fight. And so it inhibits the dorsal vagal. It inhibits that shutdown reflex. And then the ventral vagal comes online. And the ventral vagal is more associated with what's called neuroception. And that's where you read someone's face, you listen to the intonation of their voice, you watch their nonverbal cues, and you say, is this person trying to hurt me? Or is this person going to help me? Or is this really just nothing? Do I just, say they're not doing anything, or not even paying attention to me, and move on? So that's the ventral vagal and system and neuroception. So that system then kicks in and says, hey, we don't need to run away or fight that person. Let's reason with them, or let's avoid them, or let's talk to them like this, right? This is where we see a big breakdown in autism. We see a big breakdown in, really anything, right, that I described earlier. Depression, anxiety, all these things, right? What if someone's reading someone's face wrong and their sympathetics are firing because their ventral vagal system is not strong enough to then say, no, that person is just having a bad day, or that person isn't really talking to you, or whatever. So your sympathetics start to fire, right? And then what if there's nothing to run away or fight, right? And so then you start to sequentially degrade into the dorsal vagal, and you start to become fatigued, you start to shut down, etc., right? So that's kind of how that works. I just explained this yesterday to a parent who is asking me, why does my child interact with adults better than his cohorts, right? And this was about a 4-year-old kid who we are working on developing his ventral vagal system, right? And I was having trouble really driving this home, but then I finally explained, have you ever sat across the table from a literal psychotic person? And, the mom had to kind of think about it. And I said, a psychotic person is not going to have proper nonverbal cues. They may look right at you with a smile, but want to rip your face off. They may say something that could appear just mean and just gnarly, but they don't realize how they're saying it is hurting your feelings, right? So you get this reading from this person that is dysregulated from like how you should be interpreting it, right? So you get this association where your ventral vagal system is saying, I don't know how to read this person, so I'm going to then degrade to my sympathetic tone. And you start to get that uneasiness. Your heart rate starts to elevate just from being in the room with this person, right? And then if that's triggering, right, even more triggering because maybe you grew up with a narcissistic parent or someone like that, well, now this becomes an even stronger response for you. Maybe you develop a panic attack even just from being in the room from someone like this, right? Maybe you completely shut down. Maybe you develop a migraine, right? So that's how this works, right? So that's how this 4-year-old kid, because these other kiddos are still developing their ventral vagal system. So that process of neuroception was not really fully solidified for that kiddo. It was dysfunctional still. And so he was very uneasy playing with his cohorts, but when he was with adults, specifically family members, etc., well, that reading is black and white. He knows if his parent is mad, he knows if his parent's happy, he knows what to expect, but he doesn't get that from his cohorts, right? So that's how I tried to explain that. So I hope that helps to explain the fear paralysis. I know that's kind of a long discussion, and really that begins to touch the tip of it, because it then goes well beyond that into different parts of the brain. I'm not going to get that detailed into all the different parts of the brain, but I do want to talk about it a little bit. So let's turn to the research a little bit. And the study here that I like to reference is called the Defense System of Fear, Behavior and Neurocircuitry. So it says a distinction is made between anticipatory defense behaviors released by potential dangers and those elicited by effective dangers, especially predators. The neural mechanisms serving the defense system constitute a hierarchical network with the amygdala as point of convergence, right? So I talked about that polyvagal response, but now we need to talk about the amygdala. So most people that have been learning from me for a long time, they know that I typically teach on the amygdala and I call it the asshole amygdala. But what I've learned more recently over the past year or so is that, the amygdala may be an asshole at times, but at least it's helped me to survive, right? So I've taught, especially people with CRPS and PTSD and all these types of people, I've taught them how to thank their amygdala, literally be in gratitude for this response. And we'll talk about why later, but because it's promoting survival. But the amygdala is really about emotional regulation. And if I could really boil it down, the amygdala is concerned with 3 things. Is this painful? Is this pleasurable? Or is this nothing at all? And that's really how it's grading everything. And so if the amygdala reads something, again, through this process of neuroception, if it reads anything as painful, it will then fire into the sympathetic nervous system. It will also fire into the dorsal vagal complex. So something to really note here is that the amygdala firing into those networks are done via some of the most efficient pathways in the brain, spiny motor neurons. And this pathway, of course, was developed to keep us safe and to promote survival, but it also makes it very difficult sometimes to thrive. So if anything tells the amygdala or reminds the amygdala about a traumatic event or a potential threat, it will then begin to fire into the sympathetic tone and the dorsal vagal tone. And we then are reliant on the ventral vagal system, but even heavier on the prefrontal cortex And then there's implications within the vestibular system to come in and scale and grade and dampen that response. But those are going to come in slower because, again, those spiny motor neurons are so fast. So you may get this rush, right? This feeling in your stomach, this feeling like, oh my gosh, I gotta, punch this person, or I need to do this, right? But then quickly coming after it, you then start to feel that prefrontal reasoning of, okay, they're having a bad day, or if I punch them, I might go to jail, or, you start to reason with the scenario, right? But it comes after that initial gut punch, right? That initial, I just want to respond. That initial feeling is the amygdala firing into those networks. So again, this is coordinating fight or flight defense, but then also is turning on these freezing mechanisms, which we'll talk about, avoidance reactions, submissive postures, tonic immobilization, hypoalgesia, which is where you don't feel your body, you actually become numb. And why? Well, because a predator may be about to bite you, or you might be about to, get beat up or something like that. And so your body starts to release opiates, so you become numb. And autonomic arousal, right? And we'll talk about this a little bit more, right? So freezing. So like I was saying, when the dorsal vagal networks, when that older parasympathetic nervous system starts to fire, especially too much, you will begin to freeze. It will begin to shut you down. This can look like what they call tonic immobility. That's where you still appear to have muscle tone. It's not like you go completely flaccid. You still have muscle tone, but you see these neural circuits start to shut down motor responses. You become frozen. For those that have been in traumatic events like rape, like physical abuse, emotional abuse, so many people that have gone through these scenarios feel like some of it is their fault, because they'll say things like, I should have done something. I should have stopped that person. I should have left the room. I should have this. I should have that. But it was in fact this freezing reflex within the dorsal vagal network causing you to become tonically immobile. And there's a purpose for that. Again, you get this rush of hypoalgesia. Your body is flooded with opiates. You become numb. You become frozen. And that's part of a survival mechanism that your brain is trying to do for you, right? And again, it's very, very efficient. It's done via spiny motor neurons. It's done, and when it happens strong enough, it can actually override the prefrontal cortex in these intense emotional responses. And that's why people in the military, they have to train themselves to overcome this, right? They go through boot camp, they go through repetitive training specifically so that they can overcome this fear reflex, so that they do not freeze when they need to pull the trigger. They do not freeze whenever someone points a gun at them. It takes heavy, heavy training to be able to actually not react like this. And even people in those scenarios that are properly trained will still sometimes not be able to respond appropriately because of how strong this neural reflex is. So, but you freeze because your body's conserving energy, right? So even if you freeze for moments, you're conserving energy so that you can then flood your sympathetic nervous system with enough energy to have this superhuman strength, right? This is where the mom lifts the car off the kid, or, the little lady punches the person attacking her. This is what gives you that superhuman strength. It's that momentary tonic immobilization and conservation of energy that then turns into this rush of energy through the sympathetic nervous system. Now, this is not an all or none response. That's what I want you to understand. When I learned about this reflex, I studied it and understood it as an all or none. And that's kind of the presentations I've been giving you. But this happens throughout our day constantly. What if a freezing moment is indecisiveness, right? What if the fear paralysis is preventing you from making quick decisions? What if your fear paralysis just momentarily shuts your brain down and you can't find a word? What if, all of these types of scenarios, right? And it's because of different triggers that we're going to talk about. And then following that, you get this elevated heart rate, this this moment of anxiety, this tremor develops, this whatever, right? It's because of this back and forth mechanism that happens where you go through the dorsal vagal and then you flood your sympathetic tone, right? This can be very minor or this can be major, right? But this happens every day, all throughout the day for all of us to a certain degree. So I want you to understand that this is not an all or none response. Something interesting here was the discovery and connection with the temporal lobes in the fear paralysis reflex. Basically, there were some guys studying Kluver-Bucy syndrome. So you get these hyperconnected temporal lobes. And what they did is they performed a bilateral temporal lobotomy. So they actually took out the temporal lobes. When they did that, the fear responses were gone. Now, they were gone too far, right? They were actually, in the experiments, what animals was it? I forget what animals it was. I don't remember if it was mice or what it was. But basically, the subjects would then approach scenarios like snakes or whatever it was they were presenting them with no fear, right? And so there was this close connection with the temporal lobes in Kluver-Bucy that has a lot of implications in the fear paralysis as well. So let's get into, from a brain perspective and a neurological network perspective, we've talked about various scenarios, various networks. I want to list out what I've seen clinically and then also supported in the research, the networks and parts of the brain associated with the fear paralysis, kind of a more comprehensive list than what we've done so far, right? So the prefrontal cortex, that's the king, right? Because the person with the best developed prefrontal cortex is typically going to win. That's where all your executive skills are. That's where you reason, your logic, your planning, your ability to plan into the future. This part of the brain comes down and dampens and controls these lower networks that just want to react. They just want to punch someone. They just want to whatever, right? Those animalistic behaviors. Your prefrontal cortex is giving regulation. Specifically, in response to the fear paralysis, we need to look at the medial prefrontal cortex and the dorsal lateral prefrontal cortex. And then more recently, there was a paper, actually February of 2024, that identified the dorsal peduncular region of the prefrontal cortex. So that's all for all you neuro nerds out there, you clinicians that want to know this information. In our office, we're performing, various types of targeted exercises and stimuli for these parts of the brain, maybe even neurofeedback on these parts of the brain. And then, of course, the frontal lobe, which has everything to do with movement, and the temporal lobes, like I mentioned. We already discussed the amygdala and how that's a lot of the emotional regulation in the brain. The insula, or the insular cortex, is also heavily involved. The reticular activating system is something that is very, very important. Your RAS gives you the ability to navigate the world, both physically and mentally. This part of the system is actually developing in parallel with your primitive reflexes. And that's why when we're doing primitive reflex work, we're also working on the reticular activating system via the postural reflexes, because your postural reflexes are very much involved with your reticular activating system and how it develops. Various parts of the brainstem. Vestibular system is huge. Think about when a baby's crying and you're like, okay, they're not hungry, don't appear to be in pain, what's going on? And you start moving the baby, right? Whether you're swinging them side to side, you go for a drive, something like that. That vestibular response is then gating that amygdala, right? So there's an actual connection between vestibular nuclei and the amygdala, the central nucleus of the amygdala, that then allows the amygdala to calm down and stop that consistent firing. The cerebellum, the vagal system, which we talked about, the ventral vagal and the dorsal vagal complexes. Your enteric nervous system. So this is the nervous system associated with your gut and organs. Huge implications here. What if you eat a food that you are intolerant to, right? You have this inflammatory response from eating gluten or dairy or something like this. Your enteric nervous system is picking up on that because it's constantly monitoring it. This can be a trigger that then fires this fear paralysis network, fires the sympathetic tone, fires a dorsal vagal, fires the amygdala, right? So this can actually happen. So even foods you're consuming can be a part of this story. And I'm going to talk about that even more. Trigeminal system, facial system, everything to do with facial tone and how to read a face. Sympathetics, we discussed core stability. Your core tone organizes your sensory systems, right? So that's huge. And of course, your sensory systems. A great study that I've seen is actually talking about the impact of electrical facial muscle activation on emotional state and affective processing. This means that this is a big window in for us to help here, and I'm going to show you and talk you through how to use this. But this is actually in the research. We've been doing it for, 14 years now. But it's good to see that finally in 2024, we have a study connecting it. And then, like I referenced earlier, the study February 24th, 2024 came out in Neuroscience News, actually, Unlocking the Brain's Fear Circuitry, a Pathway to Survival Responses. And this was talking about the connection of the dorsal peduncular part of the prefrontal cortex and how it can scale the level of fear that animals are experiencing via this fear paralysis reflex. There is this time frame that we need to pay attention to. So after a traumatic event, Dr. Faith Harper actually talks about in her book, and sorry, but the name of the book is called Unfuck Your Brain. That's what the name of the book is. But Dr. Harper is a clinical psychologist. I like her book. She uses some language that some of my viewers may not like throughout the book, but she makes some very good points. And I've actually read it several times, so I do like the book and how she presents everything. But she talks about this importance of honoring grief. And basically, after a trauma, there's a 90-day window of time that you really have to kind of re-regulate your nervous system, right? So we talked about how all of the ways the nervous system can go awry and all of the different responses that we can have in our nervous system from a trauma. But then we also need to understand that it's not like you just wake up the next day and that's gone. Depending on how severe the trauma is, this can be extremely dysregulating to your entire nervous system. And there's an important 90-day window of time. And it's not like 90 days like to the day, right? It's going to vary depending on the person. But the first step is we need that trauma to be resolved. We don't need repetitive trauma because it's like every time that trauma happens, number one, it's creating negative plasticity, right? So you're continuing to upregulate these processes, and that's how we get things like chronic regional pain syndrome and anxiety and multiple systems atrophy and all the things that I've talked about. So when that trauma stops, this 90-day window of time starts. And she talks about how important it is to honor the grief, right? Don't just shut it down. Don't just say, okay, it happened, now it's over, but actually going through the process of that grieving process, right? It literally is like grieving. I highly, highly recommend you work with someone trained to do this. I don't recommend doing it yourself. So finding someone that's well trained in trauma therapy would be very, very important to do that, right? So we need to understand that healing takes time. It's not something that you just wake up the next morning and it's over, it's done. Especially if there's a repetitive nature to this trauma. You need to, number one, stop it and mitigate it, but then also give yourself adequate amounts of time to heal from these things. Most people need to understand that the first step is simply understanding that it's not their fault. Remember, I referenced the freeze reflex, the tonic immobility. These neurological mechanisms are not your fault. It's just your brain keeping you safe, right? And these flares, as a lot of people will call them, or panic attacks or whatever it is, again, it's not your fault. It's simply your brain trying to keep you safe. Your brain recognized a trigger that could potentially be harmful to you, and it's trying to keep you safe, right? So understanding that. From a clinician standpoint, we need to be able to examine a patient fully. We need to understand not just their weaknesses, but we need to understand their strengths, because it's through the strengths is where we're going to be able to leverage neuroplasticity to overcome the weaknesses and help to develop those weaknesses. That's extremely important from a clinician standpoint. There is no one size fits all for this. There's just not, because everyone is so different. Everyone has a varying degree of this fear paralysis reflex going on, varying degree of cortical integrity, varying degree of enteric nervous system integrity, right? So this is going to look different for everyone. If you're going through a one size fits all program, just stop. I mean, it's not tailored for you. It's tailored for the business owner, unfortunately. Fear responses can be inherited. Let's remember that. You may be primed via epigenetics for anxiety or for a gut disorder or for headaches or migraines or whatever, right? And that could have been from your great-great-grandparent going through a war, right? So we need to understand this. Also, that perceived threats and actual threats are different but the same. Let me say it again. Perceived threats and actual threats are different but the same. What does that mean? That means that your brain is always subconsciously looking for threats. It has to. And you'll find this, some people call it negative bias from the psychology world. But again, your brain is trying to keep you safe. So if your brain perceives a threat, a flash of light, a sound, a thought, a feeling, whatever it is, it can be any sense, it will fire the same networks as though a bear is running after you, right? Or as though you're coming in contact with that person that raped you, or whatever it is. That perceived threat fires the same networks as an actual threat right in front of you because your brain is trying to keep you safe. We need to understand that. And again, working with a qualified mental health practitioner, this is why we bring in, we work so close with Dr. Jerry Levine. She is a clinical psychologist, so she helps our patients in many of these scenarios as we're going through the functional neurology component and developing these brains and working through developing neuroplasticity. This is a big reason why we have to have someone on board to do this with. Okay? We need to understand that circadian biology is absolutely going to be affected in all of these individuals. We see that consistently in the research. And I want you to go back and listen to the circadian biology podcast that I went through because I don't have enough time to get into that here. And again, I discussed cellular senescence and neuroplasticity because negative neuroplasticity is really what we're talking about, where we have these chronic exposures to these perceived threats, firing these pathways, and now they fire easier and more efficiently every time they fire. And that's why the first step is identifying the trigger, mitigating it, and or eliminating it. So I do want you to go back and again, reference the podcast that I discussed on the circadian biology, because there's so many things that I talk about that you can do in order to gain and reestablish that proper circadian rhythm. And this is so foundational in where we start with all of our patients, because if this is disrupted, then you have cellular disruption at so many different levels. You will have inflammation, promoting cellular senescence. You will have so many different things that really we need to get to the root of it, and that's circadian biology, right? The two biggest things, proper light exposure and timing of food, right? So I want you to go back and listen to that. Speaking of light, we are embryologically wired for an intimate relationship between light and our nervous system. This is fact, right? So we need to understand that we can leverage proper wavelengths of light in order to have a cellular response, but then also have a network response within our brain. So if we have someone in this anxiety state and they have a lot of high beta waves, we can use red infrared light. We can dose it appropriately, and we can have the frequency of, let's say, a theta waves, right? Or whatever that person needs. And we can use that transcranially. We can even use it over someone's abdomen or other parts of the body to actually start to reestablish proper brainwave patterns. And that's something that we do every day in the office, right? And that's a big reason why, not just the reason, but I mean, there's one of the many, many reasons why I've actually have been developing new lasers over the past year and a half. And I'm extremely excited to be releasing those. I'm going to do another podcast specifically over photobiomodulation, where we're going to start to get into the nuts and bolts of that. And it's going to be several parts of a series, because that's probably going to be a very long podcast. But that's a huge reason, because you can have a big influence on someone in these states with fear paralysis, anxiety, neurodevelopmental disorders, all the things that I've mentioned, by using properly modulated wavelengths of light, pulsing it appropriately with all the different parameters that we've built into these new lasers. So very important. Okay, so let's talk about triggers. So you've heard me kind of mention triggers a few times throughout this, right? So something has to trigger the amygdala. Something has to trigger the nervous system in such a way that there's a perceived threat, right? So we talked about a little bit about physical triggers, right? The way someone looks, the way someone touches you, or, those types of things. That's kind of intuitive. So I think everyone kind of understands that. But you can also have mental emotional triggers. A certain thought can go through your brain and trigger the amygdala, right? You can have specific sensory triggers, this temperature or this type of, soft texture or a food texture or something, right? What about, again, going back to the autism population, food textures can be very triggering. Well, that makes sense because of how the ventral vagal system is heavily implicated with eating and all of the facial oral muscles and everything, right? So you don't have a proper ventral vagal tone. And now that food texture is triggering a fear paralysis reflex. You can have immune and infectious triggers. What do I mean by that? Well, at this point, most people kind of understand that we can develop neuroautoimmunity. We can develop these situations where the nervous system begins to attack your own tissue, right? So whether that's a receptor in the brain, like in PANDAS, right? Pediatric Autoimmune Neuropsychiatric Syndrome. We can have PANS, which PANS includes PANDAS and PATANS and other types of neuroinfectious immune disease states. But basically, what I'm saying is your immune system can begin to attack different receptors and tissues in the brain. Now, let's just talk about PANDAS for a little bit, right? Because that's associated with strep A. PANDAS, now, every time someone comes in contact with strep, that then is a trigger both for the immune system. But again, what about the enteric nervous system? What about the cellular response that's saying, hey, there's a strep bacteria here? All of that is also talking to the brain. And now the brain is going, fire the alarms, because every time I have a strep infection, all of this stuff happens. And so now you start getting this exaggerated effect because of the sympathetic tone, the dorsal vagal system, et cetera, right? So it's not just the infectious trigger. And in fact, you can remove the infectious trigger, but you still have this central upregulation of this fear paralysis reflex. So now you can even have a viral or bacterial contact that's not strep, but it looks like strep, right, from a microscopic standpoint. And your body goes, well, that's not strep, but it kind of looks like it. And so it fires those same networks, right? Or maybe you start to get allergies and your body goes, okay, timeout. I'm getting that, a similar type of inflammation. I'm not feeling good, et cetera. Fire the alarms, right? So this is even implicated there. Now, what about our mold population, right? What if, so I have a business partner, Kyle Daigle, and he says he knows when someone has a mold issue because his calf starts to twitch, right? So there's a scenario where you had a mycotoxin or a mold exposure, and it was very toxic and knocked out your immune system. You had a legitimate problem there. And mold is inflammatory to everyone, but everyone's going to have a different immune response to it. And so it can completely knock someone down, where for another person, it can, cause someone to have like sinus issues. So you're going to have this varied response depending on the immune system. But after you've recovered, you have this system in your brain. And when you walk into a moldy building, your brain, your cells are sensing those molds and those mycotoxins. And now it's saying, hey, amygdala, got this problem. Last time I had this problem, this is what happened, right? So now you start to get this upregulation in the system just from the exposure, right? So it's not all immune based. It's not all inflammatory based, although those are large components. But this is why it's very difficult to go into remission when you have these issues, any type of neuroautoimmune or any type of autoimmunity in general, if you do not address the negative neuroplasticity that has been caused from these events. So if you just lean on functional medicine, which I think is great, you're still missing the big piece of creating the positive neuroplasticity and rewiring these networks to fire better. And of course, we have situational, situational triggers like, the spouse, the boss, all those things. So those are the triggers. And again, the first step is finding and mitigating it, right? So you have to identify the trigger, sometimes quantify the trigger, and you need to eliminate the trigger, or at least build ways to navigate through those scenarios. And that's where someone like a qualified clinical psychologist can really help. And I talked about a little bit being thankful for this fear response. Number one, that consciously activates the prefrontal networks, right? You have to actually say and mean and be grateful for the fear response. I'm not saying like just going, okay, I'm thankful for this. No, I'm saying like actually mean it and feel it so that you actually get network activation specifically in the prefrontal cortex. Fear and gratitude cannot coexist in the brain and the body, period. They can't. So by being thankful for scenarios, right, you start feeling that panic attack coming on. You start feeling the chronic fatigue. You start feeling the pain. You start feeling whatever it is. And you start doing some breath work like we're going to go over. You do some physiologic size, start doing some of the different types of exercises I'm going to go over. And then you literally say thank you. Thank you, body. Thank you, amygdala. Thank you for keeping me safe. Thank you for helping me to survive, etc. But actually meaning it, because fear and gratitude cannot coexist. Again, we're going to talk about how to activate the prefrontal cortex. There's various desensitization techniques that we walk through in our clinic, and there's all types of techniques, things like EMDR and things like this that have been very helpful for people. We talked about addressing circadian biology and then addressing senescence. So let's talk about, from a nutritional component, some nutritional items that we find to be very beneficial. Number one is an amino acid called L-theanine. This helps to produce GABA. This helps to calm you down. Very safe. Again, it's just an amino acid. This can be very beneficial. I do like to use CBD. We actually have a Neurosolution brand of CBD that's been developed. It's very effective, very clean. We don't use any kind of herbicides or pesticides. We have some of the strongest CBD on the market. It goes all the way up to a 10,000 milligram bottle, which is the strongest on the market. We have full spectrum and broad spectrum. I personally prefer the full spectrum. It's legal amounts of THC, so it's 0.3%. But I do find that it does help me better in my patients. But some people do need that broad spectrum with the THC taken out. Two things that are very important here: B vitamins, so that's B as in boy. Finding a good B vitamin complex. I like B Replete by Numedica, but finding that is very important because chronic stress is going to deplete your body of B vitamins and minerals. This is established. That chronicity of the stress response is going to nutritionally deplete your body. So making sure that you reestablish mineral stores and B vitamin stores. When it comes to minerals, yes, I like Cellcore's CT Minerals. I think it's a great product, but I also like getting minerals from a product called Shilajit. Shilajit is high in humic and fulvic acids, along with all the different trace minerals. I do actually have a product I like. You'll be able to find it on my website, so drbrandoncrawford.com. There will be an area there to find some of this stuff. DHA, so docosahexaenoic acid, is vital for neuroplasticity. DHA was also the primary photoacceptor in the brain. This is a big reason why we have such the big brains that we have developed. So I think everyone and their dog need to be on DHA. Sorry, I don't really treat dogs, so that's just a statement. I'm not saying go and give your dog DHA, although I'm sure it would help their brain. So from a peptide consideration, again, when I'm talking through all of this, I want you to be working with your medical provider. I don't want you to just take my word for it here and go start getting on these things, especially when it comes to peptides. But the peptide called Selank, Selank, this is a powerful peptide. It's very safe. It has been compared to benzodiazepines in the research. There's studies that actually show it's more effective than benzodiazepines, and it's non-habit forming. So, and plus you don't have to inject yourself with it. It's actually a nasal spray. So again, very powerful, can help with anxiety, has actually been proven to improve cognition, helps with neurodegenerative disorders, helps with really just brain plasticity in general and calming things down. I take it. I have many of my patients on it. I've even given it to kids. Again, work with a medical provider. Peptides can be amazing, but they need to be used properly. I could go on, but that's kind of my short list from a nutritional standpoint. Okay, so let's get into the fun stuff. So we've talked about how bad all this stuff is and all the things that it's going wrong and all the things. But now let's talk about how to actually reverse this stuff. And this is specifically more for the people at home. So let's talk about it. So we first need to understand how to activate the ventral vagal networks. So again, that's cranial nerves 5, 7, 9, 10, and 11 largely is what we're looking at. For the vagus nerve, that's cranial nerve 10. It's hard to really beat. It's hard to find something better than symbicontia stimulus. And symbicontia, that's that little spot in the ear. You can Google symbicontia, Cymbaconcha, to see an image of it. But this is a very, very special place. This is a pure sensory branch of the auricular branch of the vagus nerve. We love to stimulate this with a pulsed radio frequency device called the StimPod. I have yet to see anything that has outperformed this StimPod stimulus on the symbicontia. I just haven't seen anything. And I've looked at so many things. Specifically, I've seen it outperform everything, like even the stimulators that go on the neck, all the things, right? But you can stimulate this even with vibration. So you can use a Z-Vibe, you can use a Resimax, you can use all types of things to stimulate the symbicontia. You can even tap it with your finger. You can use a piece of metal like your key or something like that and stimulate it. But this is a very important area to stimulate. You can vibrate over the vocal cords. Obviously, don't take like a percussor and damage your neck, but vibration over the vocal cords. If you think about when you speak, that's firing parts of the vagus nerve and that's vibrating the vocal cords. They're innervated by the vagus. So if we vibrate them, this will in turn start to activate the vagus nerve. Very similar to humming or singing. That's activating the vocal cords, right? You can vibrate the abdomen. Again, this is a great use case for a Resimax. If you're wondering what the heck is a Resimax, you can, again, go to my website, drbrandoncrawford.com. You can actually use a code that will give you a discount, which is my last name, Crawford, so Crawford. When you go to purchase a Resimax, it'll give you some money off there. But this is a great device. You can, again, vibrate your vocal cords, your symbicontia, your abdomen. You can also do gag reflexes. So every time I brush my teeth, I want to gag myself 3 times, right? This fires all of these great cranial nerves that then begin to fire the ventral vagal complex. Breath work. I prefer the physiologic sigh here. The physiologic sigh is basically where you take as deep of a breath in through your nose, and once it feels like you can't take any more air in, you do another quick breath through your nose, and then you let it all out slowly through pursed lips, through your mouth. So it literally is just, but I'm not going to do the whole thing, but basically as deep of a breath in through the nose. When it feels like, okay, I can't take any more in, then you do this quick little breath in through the nose, and you let it all out through your mouth very slowly. Most people, once they do that about 3 times, they start to feel a little lightheaded. Once you start to feel like that, take a break and then do it some more. But this is very good for those really stressed out people, high anxiety. It's really good for them. But there's all different types of breath work that can be done here. That's just one of my favorites. Yoga Nidra is something that is highly beneficial. There's various types of Yoga Nidra practices. You can go to Spotify, YouTube, etc., and start a daily Yoga Nidra. You can do vibration and electrical stimulus on the actual face. So again, you can take that Resimax, which is a vibrational tool, and you can start to vibrate the face because of what I referenced earlier, the connection of this face and the fear paralysis reflex. You can vibrate it, and then you can actually use electrical stimulus. Yes, you can use a TENS unit, and I would just put it on the cheeks. I prefer a microcurrent device. We use a Sabo product, which is microcurrent. It's just more comfortable, and it's, in my opinion, better for neurological rehab. And literally just, stim the face for like 20 minutes a day, or use it in those moments where you feel an anxiety attack coming on, or you feel a pain flare coming on, or whatever it may be. You can also do muscle contractions in the face. So you can literally like wink at someone and contract the whole side of your face. You may notice that one side of your face is more difficult to contract than the other. That's the side of the face that you need to contract more, right? So for me, my left side of my face, and if you see me on YouTube, I'm winking at the camera, contracting the side of my mouth. The left side of my face is a little more difficult to contract because of my neurological imbalances, so I'm going to focus more on that side of my face. Vestibulo-ocular reflex with gaze fixation. So literally, if you put your thumb in front of you, your eyes are locked onto your thumb. I'm going to begin turning my head side to side at a rate of about 1.5 hertz. So if you're on YouTube visually watching this, you can see how fast I'm doing this. But my eyes have to stay locked on my thumb. And now I'm engaging my vestibular system and my frontal lobes, again, to overcome that amygdala reflex, right? So this is all about engaging the networks that are needed to then dampen and control this fear paralysis reflex, right? Then we move up into the prefrontal cortex. There's a device called the Mindy, which I really love. I really like using the Mindy. I like using it on patients. And it's like a band that goes across your forehead. It has a near-infrared sensor that goes over the prefrontal cortex. And you're basically focusing on the screen. There's a ball that you focus on. And as more blood flow goes into the prefrontal cortex, the ball starts to move up, right? So you get this feedback mechanism of when the ball goes up, okay, that's a conditioned response, you get a reward, and now I'm training my prefrontal cortex to have more integrity and more blood flow. You can go to my website, drbrandоncrawford.com, and see more information about the Mindy. I do, again, have a discount code for you, and that discount code is Brandon15, so BRANDON 15. And again, I'll have a link for that on my site. Another device would be the Brain Tap, which is really good for walking someone through meditations, etc. Again, I'll have more information on my website. And then cold plunges. I love cold plunges for many different reasons. Obviously, you get a big activation of the vagus nerve with a cold plunge. And that's because of how blood vessels constrict and then have to dilate reflexively. So the vagus nerve is part of the parasympathetic nervous system that after that reflexive constriction of the blood vessels, the vagal system then turns on and says, okay, we need more blood flow down there. And so it activates the vagal response. But you also can get a huge dopamine rush from this. So once you come out of the cold plunge, there's studies that show you get an increase in dopamine by up to 250%. One thing that I see very common in people with a very strong fear paralysis reflex is this concept of not being able to look into the future, not being able to plan, and really they start to lose that prefrontal integrity, right? That executive skill to plan. We need to have this drip of dopamine throughout our life. And one way to stimulate that is to have goals and to be able to look into the future. Because a lot of our dopamine story is actually navigating the journey of how to achieve XYZ in life, right? But these people are not able to do that. They're just trying to live minute by minute, day by day. So doing these cold plunges starts to rewire and turn back on these dopamine networks. So that's a big reason why I like it. If you're doing cold plunges, what I want you to do is, if you're new to it, start with the water at about 60 degrees Fahrenheit, maybe 55, and just try to shoot for about a minute, right? 30 seconds to 60 seconds. The first 3 times are not going to be fun. They shouldn't be, actually. You have to actually get this painful response in order to get that dopamine rush. If you get in and you're like, oh, this isn't bad, it's not cold enough. When I do my cold plunges, I'm usually doing about 40 or 42 degrees. Because I need it to have that bite whenever I get in. I need to go, shoot, this is not fun. Because that's where you're going to get the dopamine surge. And then I'm usually doing around 6 to 8 minutes. This past weekend, I actually did 16 minutes, which I was cold for the rest of the day. I was probably a little too long, but it was good nonetheless, right? And then also using light as therapy, right? So in Neurosolution, we have LED panels, which I like because you can actually select the frequency that you want the light to pulse at. But then what I've said, like I was talking about earlier, I've actually designed new lasers that are going to hit the market at the end of May, which are going to be just amazing. They're going to disrupt the industry in so many ways, but I'll give more information there. But you can have a big influence on cellular health and then also network activation within the brain with how you use laser and light therapy. So that was a lot. But I think that this topic deserves a lot. And honestly, I think there's more to talk about in this subject, right? Regarding the fear paralysis and all these mechanisms. I hope that this maybe clarified some things for you. Maybe you were that trauma survivor. Maybe you do have someone with, you do have CRPS, or you do have a kid with PANS or PANDAS, or whatever it may be, right? I hope this was good information for you. Even if you're just that chronic migraine or headache sufferer, I hope you gained something, right? And I hope that the tools that I gave you, the tricks, the neuro hacks that I gave you will benefit you. And if you know someone that has any of these issues or could potentially, use some of these tools or some of this information to help their life, please share this information and let them know about it, because that's why I'm here. Again, I started this conversation with talking about how many people have been reaching out since we started the podcast. That's exactly the goal here. The goal is to change healthcare. The goal is to really, really help people in some of the darkest moments, or really just to understand what's going on with them, but then also have tools to mitigate it and to live life better. So again, thank you. I really appreciate you and look forward to next time.
We hope today's episode has inspired you to take that next step toward your best self. Remember, the path to longevity is paved with small, daily decisions. Your journey is unique, and every step, every choice, brings you closer to your ultimate vision of a healthier, happier life. For more insights, tips, and resources, visit drbrandoncrawford.com.